Greetings everyone. We're going to be talking about wands and dilators tonight. So I would love for you, this is the first live I have ever done. And so I'd love for you to just say hi and tell me where you're from and just make sure that you can hear me so that we know we're on the right track here. And then I am so excited to talk about all this stuff tonight. So say hi and where are you from? I'd love to know. This was totally, by the way, impromptu, other than the fact that I knew at some point I wanted to talk about this. I had made that quite a while ago, the sign about it, but this is the first time I'm actually doing a live. I see Jane is on here. Hi, Jane. And Felicia. Awesome. So hi to everyone that's joining. So one of the things I'm going to do is share quite a biased look at dilators and wands, okay? And I think what you're gonna find is that it's, in some ways it may be things you've always heard, in other ways it may challenge some of your thinking. So I hope to look into that and see what you think. And if you have any questions, please ask. So I'm gonna go ahead and turn some music off and we are gonna go start. We have a lot of people jumping on. Okay, so let me first show you what wands are, and then let's start talking about them. There's distinctly a reason to potentially use a wand, and there's potentially a reason why someone would choose to use some form of a dilator, okay? And so a lot of people ask the question, can you use one instead of the other? In other words, can I get a dilator and use it the same way I would a wand? Or can I get a wand and use it like a dilator? And there are answers to this, it depends, and we're gonna go over some of that as well. So I'm going to use, I am known, if you don't know me, I am a pelvic physical therapist for 19 years. I'm also been trained in sexual counseling through ASECT, and I am also a personal trainer, so I kind of cover all of those things. But one of my big passions is working with those with pelvic pain. And I feel like over those 19 years, I've seen so many people bring in lots of bags of these things and say, I was told to use this, but I still don't know how. Or I was told to use this and I still don't know how. And so they come in with all this stuff, but they're still confused. They didn't get a lot of directions, or they may have not received the right directions. So we want to get to the bottom of that. So hi everyone, I see you've joined and hopefully you can hear me. Please just someone say I can hear you, just so I know that we're on for sure as we move forward here. Hopefully so. Okay. So this is a wand. Oh, good. Someone said we can hear. That's awesome. I was concerned about that. So I want to show something to you. I think that is really valuable. A wand is only as good as the reason why you're using it, and that goes for any tool in general. The tool is only going to be as good as the reason you're using it, and does it make sense, okay? I will tell you this, my bias is I tend to give a lot more dilators, and I'll explain why, than wands, but there's a reason, there is a place for wands, and I want to explain what that is. So just so you know, I'm trying not to do a lot of product placement. I just happen to have some favorite products that I use. But I don't want to necessarily say that all products, you should only use one product or another. So I'm going to try to stay a little bit unbiased in that regard, but I will be pointing out some of the kinds of things that I like, and just to give you some information about them, just so you have some of that information, okay? So a wand, okay? This particular one is by TheraWand, there's Easy Wand, there's a variety of other wands out there. If you'll notice, with this particular wand, it has a curve to it, okay? So it's going to be different than if you're using a dilator, and this is the reason. We should back up and say that wands and dilators, what I'm talking about tonight, has to do with pelvic pain, so pelvic pain conditions. Now, to take it one step further, these are people that either have hypertonic types of pelvic floor muscles, so the muscles are very tight, or it's they actually have a problem where it's not only tight, but it's actually drawn in towards their body. So it's almost drawn up towards the head. That deep transverse perineum might be drawn up a little bit. So that may be another indication. And then it could also be painful. So this is where it gets interesting. Vaginismus, so pain upon the attempt of putting anything inside vaginally. Or it could even be deeper dyspareunia. So there's a pain with any kind of deep sexual intercourse type of movement where you're going inside. Now this can be intercourse, this can be a finger, this can be anything that you're trying to go inside the vagina. And what we're talking about tonight is primarily vaginal, but I will touch on rectal as well when it seems to come up. Okay, so it just depends. So here we are. I never thought I would be in my life talking about dilators and wands on a Tuesday night, but here we are. So basically, this wand, I want to show you, there's a few different ways to show you. The best way I can do, and many of you that know me know that I do a universal opening. This is a vaginal opening, okay? So let's say, whether it's vaginal or rectal, someone is sitting at home saying they feel a lot of tightness and pain inside vaginally. They feel like their muscles are really, really tight, and they feel like they've tried maybe even muscle relaxers, or they've tried going to physical therapy, but they still want to be able to do things at home that may be helpful for them. So one of those things could be to use a vaginal wand, okay? So it could be helpful. It could be rectal as well, okay, depending. There's different ones that are made also for rectal that are longer. So if we go back to our universal vaginal opening here, what you'll find is that sometimes the directions aren't explained very well. So when you go inside, the idea is you're trying to get these muscles to relax as you go in. Some people are very aggressive. They've been taught that they need to go in quickly and then do some aggressive trigger point stuff. And they're going in tight, tight, tight. They're going over trigger points. And I want to tell you that this is my bias. I don't believe there's a need to do heavy trigger point work. Now, having said that, the caveat is that someone could actually go and find a point that bothers them. There's a tender point, and they feel that when they press on it with this kind of wand, they feel a lot better. It does seem to calm down their symptoms. Then by all means, go ahead and use it that way. However, for many people, they'll say something like, well, I was instructed to push on all the tender points a lot. Like they'll say, I keep pushing, but it seems like my symptoms get worse, or they'll complain of just more soreness or tightness after they use it. Then the point of using this would not be correct if you're using it in that manner. So I see this such a widespread misconception that they should be actually trying to push and push and push on trigger points. I'd rather you say, if there's a tender point and it feels good to go and press on it, then go ahead and do that. But do not use it in the way that it's often told, which is you have to press or you'll never get rid of your trigger points. That is a complete misunderstanding of the information, okay? So if there's any questions on that, let me know, because that can be a huge point of contention for a lot of people to talk about trigger points. Okay, as we move forward, the way that I really love to use wands, if someone says, hey, I really want to use a wand at home, I want to have a way of doing that. What I actually really like to do is I'll show them this in the office. We put this in vaginally or rectally, depending on what their issue is and where they need it. We go in with the wand and basically attach to an area. Now, if you look at this like a clock, if this is 6 o'clock and this is 12 o'clock, I don't know if you guys can see that. Again, this is my rendition of a vaginal opening here. If you see that that's 6 o'clock, you would actually hook that in and do a gentle stretching of that, gentle stretching motion here, okay? Some people, I just have them do it as a desensitization. So I just have them touch this area and hold it so that they get used to something being there without associating with discomfort. So it can be even used just for that. But often we actually have them gently try to stretch a little bit, stretch here, hold for anywhere from 10 seconds to a minute, depending on how comfortable they feel and if it helps them. And then relax. And then you can go to 7 o'clock and do that same thing. And then relax. And then you would just go around the clock where it feels good. So it does hook in a way that you can get some really nice, gentle tension around it just to stretch a little bit. So this is the other point of contention that comes up. Do you believe that we are really stretching the pelvic floor, or are we potentially doing more of a neuromuscular facilitation or a neuromuscular input to the muscle? And I would argue that when you're doing this, when you apply pressure, you're basically sending a message that goes to the brain that says, okay, something's there and it's gently stretching. It gives some feedback to that area. You're not necessarily pulling to the point where you think you're really going to stretch something out, okay? So once I give a lot of that instruction to gently just stretch there, it's not really the stretch, it's really actually a form of neuromuscular facilitation or even inhibition in some cases where you're actually inhibiting that muscle from getting as tight. It's almost like another tool that we can use if we use it in that regard, and we explain it that way to patients. When I see patients that have come in from injuries from these kinds of things, that can happen very rarely, but it does happen. When there's an injury or problem, they were told to be very aggressive, or they thought at home to be very aggressive. So they go in and they're just, jamming on everything, a lot of that. And that can be too much, okay? You wanna make sure that you're being very kind to the tissues inside vaginally or rectally. Okay, so there is a place for wands, and you'll see I have a whole stack of things here. Let me see if I can find the other one. I'm already having a problem locating it. I don't know where it could have gone. But anyway, so there's ones that are thicker than this. And actually, I ask any of you out there that use wands a lot, I would be curious. I tend to prefer the smaller, the thinner ones, both vaginally and rectally, just because I think for a lot of patients it doesn't feel as intimidating, nor does it hurt as much sometimes going in. It's a little bit smaller for entry. But there are some people that do recommend thicker ones, and I'd be curious to know why. Like I said, I tend to be one that goes with the smaller one. So if you do them, you use them with patients or clients, and you happen to like the larger one, I'd like to know why, if there's a reason. The one thing is sometimes people that have what's called a hiatus, they may have a larger hiatus here at the opening. They might actually just prefer something that's a little bit bigger to stretch. But for the most part, I think you can get away with something like this. There are some that are longer that are meant for rectal, so you can reach and do that on your own. So that is an option now. Some of the companies out there offer that, okay? So do we have any questions on the wand? So just to review, the wand is good for gentle, almost like I said, a neuromuscular facilitation, a stretch, as well as a way to very gently do some what we call ischemic pressure, or just pressure on an area if it helps. If you press on that area and you say, that feels much better, then that's fantastic, and that can be part of a home program. The issue I have with wands is how they're instructed sometimes to be very aggressive and or pushing as if your life depended on it on these so-called trigger points. And the problem is, and a lot of people don't know this, is if you keep going back, you're gonna hit the ischial spine, which is where the pudendal nerve is very superficial at that area. If you go up towards the pubic bone, you're also very close to the dorsal aspect of the pudendal nerve. So that also could be that you're compressing and irritating a nerve a lot. So if I can be of any assistance to that, to just say, be kind to the vagina, be kind to the rectum. And there is a place for this, but I want you to know that this is not for everyone. I have some patients that just don't feel comfortable using anything at home, and that's okay. I have some patients that I know would be very aggressive with it because they said they want to be very aggressive, and I get concerned about that. But if a patient says, I'm looking for a tool that may help me stretch a little bit, or what you're doing right now when you stretch there, it feels good, is there something I can do at home? Then this may be a viable option for them. All right. So Robin, hi Robin, from Arizona says, I get a bit nervous if men report using them for rectal, not using them, but making sure they are being gentle. Yes. I have had some cases where people have had significant injuries, not a lot, but over 19 years, I've had a few where they were very aggressive rectally, and it did lead to some other issues and injuries. So it's not to say don't use these, but there is a time and a place for them. Well, there's definitely a time for them. You wouldn't necessarily use them anywhere, but there is a place and a way to use them that will be more helpful than being very aggressive. So anyone, definitely for rectal, but definitely across anyone that I've ever taught this to, if I am going to teach this. So from a practical standpoint, what I would do is have a patient, I either have them in the office for them to get, or I have them buy them and then bring them in so I can teach them how to use it, as opposed to just saying, yeah, go home and just go crazy with it. I definitely want to make sure that they know how to use it. Okay, so that's really important. So there is a place for this, but I'm very careful about it. Now, someone would say, well, I don't have a lot of money and I want to know what I can do. Can I use this as a dilator? And that is a great question, because technically, yes, you can. The only difference that you're gonna find is that you can't really go up in size, that this would be the size you have, as opposed to something that would allow you to keep going up in sizes. So I'm gonna show you an example of that. With dilators, and these are the plastic kind, we're gonna go over a variety of those. You have some that they go up in size. So basically I'm skipping one of the sizes, but they would go up in size, and then you go to the next size. This is the largest size, okay? So they keep going up in size. So the issue I have with the wand is that it would suffice for some of the things we're gonna show you with a dilator, but at the same time, it doesn't necessarily go up in size. You're just stuck with this. You're stuck with the same size, and that's all you can do. So there is a place for it. It's just not as functional per se as if you're trying to use it for the reason you'd be using dilators. Okay, so any questions on this? So we're going to move on. Hi, Heather in California. It's great to see people I know, and I see Amy. I see Amy's there from Philadelphia. Very cool. Okay, so let's go over dilators. There are all sorts of dilators. There's different names for them, but I would just say let's just go with dilators for the sake of education tonight. There are plastic ones. They serve a purpose in the sense that they can be used as dilators, and this is even a fancy one. This is basically a Berman set, and it has all sorts of gadgets. Like, for example, it has vibration to it, so you can turn on a vibration here, and it also has these other attachments. But I want to tell you that if anyone out there uses this attachment, I would like to know why. And I say this kind of jokingly because I find that a lot of patients find this to be way too much and too irritating, and they think they're supposed to use this or they have to use this. Now, while others really find it's helpful, it just depends. I'm going to actually make sure I have a charger going on here. Excuse me 1 second. Okay. So hopefully I'm still on there. We have these kinds of things that you have the vibration on this one, as well as you have the different sizes with the set, as well as this thing. But like I said, I don't know if I trust this one too much. This causes some issues for patients. Okay, so now we move on to the difference between plastic and silicone. I will tell you that patients who generally just have a little bit of discomfort with intercourse or are looking for something just to help aid them a little bit, and they just want something cheap, the plastic ones will do the trick. They're, usually you can get them between $19 and $40 or $50 depending on the set. They also have graded sizes. They work. They are plastic. We've seen extremes where someone really wants to save money and they will use candles, believe it or not. And then what I tell them, at least put a candle, like put a condom over the candle so that at least you're not getting the wax right on there inside. So yes, and someone asked a question about, do you lubricate the wand or dilator? Absolutely. And I'm going to go over some of the instructions for that as well for the dilators. But yes, for the wand as well as dilators, you definitely want to be, I always say, be very liberal with the amount of lubricant you are using. This is not the time to you'll see someone put just a little dot. Like, oh, no, you want to really cover that thing so you don't have any friction with the material of the dilator. So I will definitely, Flynn, I'm going to get to your question because these are all great. Is the purpose of dilator just to stretch out the area so there's less pain with intercourse? Yes and no. There's actually a whole other component I want to explain to you. And that's the misunderstanding, is that people think that dilators are just to stretch, and they're really not. I use it in a totally different way, and I'm going to explain what that is. So you have the plastic ones, then you have the silicone ones, okay? What I love, and I'm going to show you the different kinds that I use a lot or recommend. Soul Source has one that's also for transgender types of, the gender confirming types of surgeries. They have these that they're using directly after surgeries, and I think they're really, really nice and well done for that. So there are different kinds depending on what the issue is. But for the purposes of this demonstration, we're talking more about pelvic pain. So hopefully that will be helpful to know. So if someone just needs a dilator set and they're not picky about the material, these are much cheaper in a lot of ways, and people can use them. However, I will tell you that I am a huge fan of using some sort of silicone dilator if you can. The price jumps up. It may be between $10 to $20 or $25 on each one of these. So if you have a set of 8 or so, you can imagine that can add up between $160 to $210 or so, depending on the set. And that's if you get the whole set. Sometimes it's okay to just get a part of a set. You may only need 1 or 2 sizes, okay? So I want to show you that there's different kinds out there too. So for example, Soul Source, I've been working with Jane and Soul Source for, I'm not even sure now how many years. It's got to be at least 12 years or so with that company. And they're fantastic. They make an excellent silicone dilator like this. And then there's Intimate Rose also has one, and it's very similar in a lot of ways. They have similar sizes as well. And like I said, I'm trying to be very mindful that I want to make sure be respectful to all products, and I don't want to, I just want to tell you what I typically really do share and tell. And I'm happy to post the information about this after this live. I'll send information about each company, as well as anything that I know they may want to give something away or something like that. I'm happy to do that. But these are the ones that I really do use. This is straight from my clinic, all the information here that I'm sharing tonight. I'm always open to learn about new products as well, but these are the ones that I use a lot and have been very happy for many years with them. So let's go over that. A lot of people have questions about using dilators. If you go to some of the most popular sites out there for dilators, what you will find is that the information is all about pushing something in there and stretching it out. There's a lot of this idea that if you have painful intercourse or painful penetration of any sort, whether it's finger, penis, anything like that that's going inside, that let's get a big size and kind of just push it in there. And I'm exaggerating, they don't all say it like that. But the idea generally is that it's supposed to just be stretching it out, okay? But I want to tell you something that I teach in all of my courses, and I think that it's really worth understanding. We've now come a long way of understanding pain science and what happens with pain science, and what we understand about that branch of understanding pain is that pain is mediated by the brain. And all that means is that, for example, if right now there was a bear standing next to me, okay, people can just say, hey, just calm down, it's cool, it's a really nice bear. Like, that bear won't do anything to hurt you. It's a really, really nice bear. People can tell me that, and I can say, okay, I'm gonna stay calm. But my nervous system is like, oh my gosh, there's a bear, there's a bear, there's a bear. So there's this fear of, oh no, you're automatically gonna have a nervous system response that you cannot control. It's more of that reptilian brain that happens where basically it's saying danger, danger, danger. So believe it or not, a lot of people who have pelvic pain, vaginismus, dyspareunia, or deep penetration pain, or any kind of penetration pain, tight pelvic floor muscles, it has a lot to do with their nervous system rather than just saying, I have a pain right here or right here. It's actually more of a problem with the nervous system at that point that they're coming and seeking help. So what I mean by that is you can push on trigger points all day long, you can do all sorts of things, but if you're not working with the nervous system, you're still gonna have an issue at the end of the day. And that's the reason why so many people come with they have these dilators, they'll come in with bags of them and say, I already tried dilators 5 different times and they don't work. And I can tell you that I have yet to find someone that didn't use it the right way. That wasn't they were highly successful by the time they used it because there was a way to use these correctly. And I want to make sure I go over that today. And just so you know, on pelvicguru.com, there is a whole dilator guide. There's a handout, and it goes step by step and what are really good ideas to try. So you can certainly get that information there, and I can put a link to that as well, of just explaining exactly what you do with dilators step by step. Okay, I've never seen it anywhere else, and that's why I created it. It needs an update in terms of the look, aesthetic of it, but it is important that we're making sure we're teaching how to use these correctly, and patients feel like they're supported and that they understand how to use these. So someone was saying, as a clinician, do you prefer silicone or Berman? I don't know if you missed the part where I was talking about it. If someone just generally has a little bit of pain and they just want to have something to bridge between nothing and going back to any type of intercourse or sexual touch in that area, because it can be used even on the outside. We didn't talk about that yet. You can certainly use these dilators on the outside as well. If they just need something and they're not really having a lot of pain, or they just want a little bit of something, I think you can get away with plastic ones, and I think they'd be okay. And a lot of people also like the Berman type dilator and other ones like this where they have a little bit of vibration. Because technically, for some people, they find that if they turn on the vibration, and they would just use this here, they can actually apply it to the vestibule or that opening here, and they find that it does relax the muscles in that area, and they can apply it to different muscles there. So there is a place for this kind of Berman dilator, but if you were just asking me if I had to make a decision right now, I'm a much bigger fan of the silicone dilators. Almost every patient that has used this has had trouble. When we switch them to a silicone dilator, they immediately say, whoa, that makes such a difference. I feel the difference, and they really like them. So I would say if money wasn't an issue and they really just wanted to go with something that would be most comfortable, I would tell you that the silicone ones are more comfortable. What you're also going to notice, this is another brand. They come in it comes in a very cute carrying case. So this is actually, what I like about some of these is they also have a handle. So again, this is plastic. Definitely not as comfortable. I don't think it's as comfortable as silicone, but it does have a handle, which a lot of people like. And same thing with the Berman one, it has a handle. These other ones that are silicone, they just have a basically a stopper here, and you can still use them, but they're not, they don't have as long of a handle. So some people just like the handle, and that's okay. Which brings up one other thing that I wanted to talk about. I have many things to talk about with this. I feel like one of those air traffic controllers right now, actually. So one of the things too that comes up a lot is, well, I put the dilator in and it pushed right back out, so I must have really, really tight muscles. No, you may have tight muscles, but that's not the reason. You have a lot of lubricant and you have just intra-abdominal pressure and tight muscles potentially. So you just have a lot of force pushing it out. So what we recommend is once you get the dilator inside, you can do a variety of different things. You could try to put on some underwear for a little bit. You could, I sometimes have patients build a fort. So I have them take a variety of pillows and things and literally stack them up so they're all around, and essentially put something there so that it doesn't keep pushing out. Or I just have them hold it with their hand, just hold the dilator. What we want to be careful of, there are some people that say, yeah, dilators weren't a problem at all. I stuck it in and then I turned on like Game of Thrones, or I turned on some show and I just forgot it was even there. The problem with that is there's disassociation that can happen, where we actually want the person to feel that there's a dilator there. We want you to be in touch, that whole mind-body connection. We want you to say like, I feel something there, and how does it make me feel? Now, you don't have to perseverate over that. You don't have to think about it every second. You can basically watch Game of Thrones and then go back and say, how am I feeling? But you don't necessarily have to only pay attention to that, but you also don't want to completely disassociate and say, I don't know, I had it in for an hour and I didn't even know it was there. So we don't want that either. We actually want you to have a connection with this. Which brings up the next point, which is how often should you be using this, or how often and how long, that sort of thing. I've seen some people that are instructed to use this for hours at a time. They put it in, there's some glass dilator sets. They put it in for just hours, and they lie there and they just say like, hope and pray that it gets better. I do not think that's necessary. If you think about the way muscles work, I have not seen research on this, if there's an exact time, and if anyone has that research, I'm totally open to learning about it. I have not personally seen that at all. But we do know that it seems to work well if you're using it regularly. If you think about anything else for your neuromuscular component for your nervous system, if I use this 5 to 7 days a week, even for 10 minutes, just being at regular intervals, I'll have pretty good success with this. Some people may find that they need to use it for an hour, or much longer than 10 minutes. And others find even if they just have contact with it a little bit, 2 times a week, they do okay. So it just depends. But for those that are having significant vaginismus, where it's almost like if the eye were to blink, they kind of have this reflexive movement. If it's that sort of thing, then I tell them I really like a silicone dilator, and I actually have them really go gently, and may even be that they're just putting the tip in here, like just the top part of that dilator for 10 minutes. And that's all they're doing. It doesn't have to be all of it in. It's not an all or nothing thing. So they can just put it in for 10 minutes and then just relax. And we're going to go over the progression of that. But the general idea is usually I feel very comfortable saying 10 minutes and basically for 5 to 7 days a week. And this is the key for compliance we talk about patient compliance. I don't really like that word, but in terms of making sure someone feels supported with their therapeutic journey with all of this is, if someone says, I just got all these things and it's really embarrassing, I have to find time to do the dilator, and then I've got kids running in, or all these situations happen, what I always say is do the best you can, even if it's just 2 days a week. Even if you're on vacation and you decide for 7 days you don't want to bring it with you, that's okay. Then when you come back, just start again. People think that once they start, if they stop, they're starting at the beginning again, and that's not necessarily true. So I put them in a position of success where we try to figure out for them what really works. Instead of, I've seen some rigid thoughts around this, like you have to use it. They'll tell the patient, and what this is called is nocebic language. They mean well, but they'll say something like, if you don't use this 7 days a week for at least 10 minutes, you will never get better. And I don't like that. I don't like that discussion, because there's so many things that can still get better, including this with dilators, by using it less. So I really try to set up patients with for success with the language we use with this. So one of the questions is, would pelvic organ prolapse be a contraindication or are dilators beneficial? Good question. So pelvic organ prolapse, let me see if I can get creative. I usually do find ways to get creative with patients. So let's see if I can do this. All right. So if this is the opening, let me shift around here. Okay. If this is the opening of the vagina, the urethra is here. The bladder would be back here a little bit. And then you could have the rectocele coming here. Okay. Then you have, I'm going to get very creative here. Then you may also have the cervix visible or coming forward. Okay, so you can have a cervix, a uterine type of prolapse. You can have what's called a urethrocoele coming down. You can have the bladder coming down as well, and that's a cystourethrocoele. And you can have a rectocele. Those are the main ones we see that we can treat or help with. So to answer your question, if I have a cervix coming out a little bit towards the opening and I have a urethra that's down, oftentimes what people say is any kind of inserting anything in the vagina, actually what it does, it'll actually push. So anything vaginally like this will actually sometimes push things into a better position. Now, the only caveat to that is if you go in the vagina and you push, there is a chance that they'll feel more sensitivity, like, because I mean, you're literally on an organ, you're actually hitting the cervix, okay? So that might not feel comfortable, and we just have to be mindful of that. But often people say after intercourse or after using dilators, they notice that they feel like their prolapse improved a little bit. And that's because you're taking where that space is and you're pushing something back. So there is that chance you're actually helping it. But it's not a long-term solution. It is something that doesn't necessarily, definitely not a contraindication to have a prolapse and use dilators. Absolutely not a contraindication. However, there's always nuances and caveats to all of this. There are patients who have a grade 4, type 3, or even 3, really, 3 or 4 uterine prolapse, where it's actually now coming out. So it'll be sitting outside of the opening. We don't see this too often, but when you do, often because it's so far down, you'll see some bleeding and some erosion or problems at the cervix, okay? So this is a person we just try to help get it back in a better position, and they'll likely need to be a surgical candidate at that point. So this is something I wouldn't say, hey, take your dilator and keep pushing on it, because it's already a tissue that's open and has a lot of issues. In general too, if someone has decreased estrogen in the vaginal canal or anywhere here, using a dilator may also cause some friction, and they may get a little bit of bleeding with it. So that's a separate issue to deal with. That's not necessarily a contraindication. It's just that we need to deal with that issue as well. Do they need some local topical estrogen? Do they need something else there to make sure that they're not constantly causing too much friction along the walls? So no, it is not a contraindication. And technically the dilators can be beneficial, but they're not necessarily a long-term solution, but they can help in some cases. Though again, some people say it's painful and then don't use them in that case. All right, I love the questions. This is much more interactive that way, or else I'm just talking to a screen and staring at myself. So I love any questions you want to throw at me. Okay, so you're welcome. So let's see, what else can we show you here? I want to get into I'll start wrapping this up by showing the different things here. Let's see what other things. I feel like I'm doing unveilings, unboxings of things here. We've got all sorts of goodies here. So this is Sole Source. Like I said, I've been working with them for many, many, many years, and they have a great set here at Silicone. And I'm gonna show you, we jokingly say this is Big Blue here. A lot of my patients will refer to this as Big Blue. But this is where it's really important to understand the progression, okay? There are some people that only have a problem with their partner. So let's say they don't have a problem with anything entering the vagina. They can use a tampon. They can have a finger inside, but anytime they have a penis inside, they say they have a lot of pain with that, okay? So the question is, do they really need to start? I mean, with that person, do we need them to start with the small one? Probably not, okay? In that particular case, we go for what the issue is. But would I say it would be beneficial for them to start with something a little bit smaller and then move up to something like this? Sure. And then we're going to talk about that progression. But there are some people on the other side, if we're looking at the spectrum, there are some people that just having a dilator like this, if I just showed this to them, they would immediately go into that autonomic nervous system response and curl into a ball and not look at me again. Because for some people, just seeing this can be a trigger for them. So we have to be mindful of how we're showing dilators and that aspect of it as well. Lauren is saying, if a patient has been compliant with dilators but still not able to progress to intercourse, do you recommend sex therapy, pharmacological management? Yeah. Hopefully I get to that. If not, Lauren, hold me to it, because that's actually a really good question, and I think it goes to the heart of everything we do in pelvic physical therapy and sex therapy in general. I will generally say that this is all a recipe. Okay, so each person that's coming to you is going to have a different need. I have some people that when I do their exam, I immediately notice that they are probably going to do better if they had some sort of pharmacological intervention as well with so it could be a muscle relaxer with what I'm doing and dilators at home, while others I know probably 3 treatments with them without anything and they'll be just fine. So I think the larger piece is, in general, there is a little bit of it depends on the case. But I still question, if you said if a patient is compliant with dilators but still not able to progress to intercourse, I want to know what's happening at that transition point. Are we setting them up for success? They can do the dilators, but then they can't have intercourse. I want to know, are we still teaching them some options there? And I'll explain some options for that. But absolutely, at any point, I am a big fan of sex therapy. I totally believe that it can start early on. It doesn't have to be they have to go through therapy first or dilators first. Absolutely, if we think that would be helpful, we can start that out early as well. So to answer your question, I still believe, yes, that sex therapy would be a good thing. But I'm more concerned about that sentence about they have been doing well with dilators, because I can tell you that there's a high percentage. I tell my patients that for the most part, they may never need to get to this big one. This is actually a very large one that not most people have to even do or use. It can be, let's see, something like this size is really where a lot of people like to get to, something like this. Okay, I believe this is number 7 in the scheme of things, but I could be wrong. Maybe Jane's still on, she can tell us. But when we're looking at this, some people say it's weird. I can put it in, but I still feel like I can't have intercourse. Now, when I teach people, listen to how I'm explaining how to teach dilators, and then we may see that there's something missed in the interim, in that step between that and having intercourse. So come back to me if you still have a question after I go through some of this, and we'll see. And then Charlotte is asking, will continued use of dilators reduce overactivity in the pelvic floor, which leads to OAB, which is overactive bladder, or are they purely for sexual pain? Ooh, good question. Dilators, the way I'm going to describe them to you, dilators, this is why I love dilators. I am the biggest dilator fan, and the reason is because it's a form of training the nervous system. It's totally affecting the nervous system. So why that's important is, in anything, OAB is a form basically of a neural issue with the loops in the spine, and its reaction to having too much of a hyperactivity. The detrusor starts to go, making you feel like you have to go. So to answer your question with that, does it reduce the overactivity in the pelvic floor? If someone has a tight pelvic floor and they've got a lot going on there, it can certainly be one tool you could use to try and put in there to get everything to calm down. So yes, but it really depends on how it's explained to the person. If they're just handed dilators and said, just push these in and your OAB should go away, or push these in and you won't have any pelvic floor problems, they're getting a disservice done in terms of the explanation. It really depends on the explanation and what we're saying to patients. And I cannot stress that enough, because it's that important, and I think it's the difference. I've had cases, I've had 2 recently and 1 a while ago, where they weren't able to consummate marriages for 7 years. One was 7 years, one was 8 years, and one's 20 years. Okay, and in all of those cases, when they weren't able to do that, they went through different treatments and they had people try dilators with them. And the difference is that they were just told to kind of push the dilators in and just progress them. But it was missing the explanation of really listening to what your system is doing and really listening to your nervous system. And this is where we're going to go now. So you guys ready? I gotta get ready for the next explanation here. So this is my favorite thing about talking about dilators, is really the progression and what to do. And thank you, Heather. She said I had a great response. Appreciate the support. This is the thing I love the most, and why I'm doing so much with Pelvic Guru and Global Pelvic Health Alliance, is we have such an awesome group of people that we've known. Some of us have known each other for many years, and it's so great to see all the support, and I really appreciate it. So thank you. Okay, so let's go over, we still have some people on, this is awesome. Okay, I'm gonna go through actually this set just to show you a progression. Okay, so as we discussed, let's start from the top here. We wanna put a liberal amount of lubricant on. I will not get into the details of this yet, but there are some, we even recommend a little bit of lidocaine as well, but that's a side topic that I can go to if someone's interested. But for now, we're just talking about a liberal amount of lubricant so that there shouldn't be a lot of friction on here, okay? Let's use the case of someone that has significant vaginismus. And what I mean by that is if you just try to put even like any kind of finger, anything close, tampon, anything here, it almost goes into a reflexive state where it just tightens up, okay? If that happens, often we refer to that as vaginismus. Now, there's a lot of debate about nomenclature and that sort of thing, but that's also for another time. So if someone has that problem, or even there's lots of different cases that can happen. Someone says, I don't have any pain anywhere except right here. There's this one spot that's really bad. So every time something goes there, it hurts so bad that I tighten up and I can't finish. I can't even get anything inside. It just immediately makes me shut down. So there can be a tightness, a vaginismus here. There can be one that's more like just a spot or a few spots that are really tender to the vestibule here, or even the hymenal tissue that sits right there, like close to it, but not right at the vestibule. The vestibule, hymenal tissue is kind of just the ridges here. Okay, so you can have that kind of pain. And then there are those that have really, really deep dyspareunia. So it's basically at the vaginal cup if they've had a hysterectomy. It can be at the obturator muscles, obturator internus muscles. It can be directly hitting the cervix. It could be a deep sacral pain. So there's a variety of reasons why someone can have deep penetration pain. Okay, but for purposes of the dilators, we're going to talk about the first one, which is basically someone really is struggling to get something inside and it keeps going into a reflexive thing here. This could almost be a hand puppet too. I don't know what's going on, but okay. So we have lubricant, okay? And let's see real quick. Perineal massage can be very helpful. Yes. So the part that I'm jumping and skipping ahead is that there are certainly things you can do for manual therapy that are at the adductors, the inner thighs, at the perineum here before you even go there. But one thing I want to say, just because I have this opportunity in a somewhat captive audience here, is that sometimes my frustration has been, and I've talked about this a lot recently, is that there are people that have a specific problem, deep vaginal cuff or deep in the pelvic floor, and you'll see people working on their adductors and abdominal wall for 8 weeks before they even do or work or look at anything inside. And so I think there's this making sure we're not overly working on things that aren't really as important to the actual epicenter of the problem with the discomfort, if that makes sense in that regard. So yes, absolutely. The other thing I should back up and say, I have some patients that have such significant vaginismus that we don't even start inserting this. I actually have them do a week or two where they take the smallest dilator and they literally just put it on the top of their vulva. And some people tell me, oh my gosh, that freaks me out. The thought of even putting that there bothers me. So I say, okay, let's take a sheet over your vulva and put this on top of the sheet. So it's not even touching your own vulva itself. And that sometimes helps them. Or I have them put this on their abdomen or on their leg. So again, this is because it has something to do with the nervous system, okay? We're tapping into the nervous system. We're saying, what can we do to make it comfortable for something to be close to the vulva, something that would normally seem threatening, and make it in a way that can actually be tolerable. And so when people have it on their legs, or like I said, anywhere really, I mean, anywhere that they feel comfortable, that gives me an idea in the first evaluation of where we are anyway. I have some patients that the only place I can even touch them is at their knee or at their lower leg, or else they immediately get into that pattern. So I want to support them with that. Okay, so usually what I ask, and when I teach in classes, I ask two different things. I may ask about their pain, but I also ask their anxiety scale. So I'll say on a scale of 0 to 10, 0 is you are calm and cool as a cucumber. And then 10 is like, you right now, you're about to kick me and jump out of here. You just can't take it. Like, this is way too much. And you'll find that some people will say, I don't have pain, but no one asked them if they had anxiety or if you had like an anxiousness about it. And you'll find that if they have, and this is another key thing we use with dilators, so bear with me here when I say this, if they have, you want to look for a scale of 0 to 10 for anxiety. If someone has a 0 to 3 or 4, I can still proceed in some ways. But if they're telling me that their alarms are going off and they're at a 5 or 6 or 7 or 8 or 9 or 10 in anxiety scale, that to me indicates that this person is going into a full autonomic nervous system response. You sometimes even see them grip their inner thighs together. They'll go into a full guarding pattern. What's happening is this is why dilators won't work for some people right away if you're using them incorrectly, because you're literally fighting your nervous system. Just like I was talking about before, if there's a large bear here, you guys could tell me, like, don't worry, that's a specific bear, that's totally cool, like where he's cool. But my nervous system is still gonna jump. I'm still gonna be in guarding mode. I'm not gonna let that bear touch me. It's just too much. So that's why it's important to basically back that up and look at it in that way, okay? So let's say that they've gotten to the point where they feel comfortable with this being on their vulva, and again, they may not need that step. But now we're gonna go to the point where there's a point here, literally, here. What I wanna do is the same thing we talked about from a nervous system standpoint is, if I were to put something here, and I say, tell me a little bit about your discomfort. Yes, all about down-regulating the nervous system. That's what this is all about. And once you get that and use the dilators this way, it is like an epiphany goes off. It's just, it's truly practice changing to be able to use it this way. So I hope those of you who are trying to use dilators at home that have expressed some problems with that, I hope you're also seeing that there's things that you can do at home that you may or may not be doing yet. Okay, so if I put this in and it's like they say, it's a 2 out of 10 discomfort, or whoa, that's uncomfortable, it's a 2 out of 10, just as an example. I don't necessarily say, oh no, we better stop. A 2 discomfort, I want them to feel something. It's okay if they have a little bit of discomfort. What we're looking for is just gently going to the point. We don't want them to get to the point where they're a 4 or 5 or 6 or 7 or 8 or 9 or 10. We want them to be below a 3 or a 4 is what I say. And that's in that handout that's at pelvicguru.com. There's actually a handout that describes that and says, you really want to keep discomfort below a 3 or a 4. Oh, thank you so much. So people are saying I'm not a professional, and this whole session has been so helpful. Thank you. I appreciate it. Because sometimes you do these things. This is the first time I've ever done an IG Live. I love to teach. I'm always teaching professionals, but I really wanted to do more of these for the community and for everyone so that we're all on the same page. So that there's just this missing gap all the time. It's like, how do we educate and how can we get to the point where we can help more people? So I appreciate the feedback. Thank you so much. I will look at that question in a second, but I'm going to just keep going with this. So when you go in here, if someone says, oh man, I don't know, I don't have any discomfort, it's really easy. Okay, great. So then we can just put that inside, hold it there. It could be for the whole 10 minutes. Great. They were able to hold that there, had no discomfort. Awesome. Now in the same session, we could have them go to the next size. We could have them, let me get that out. We could have them go to the next size. Now they say, oh no, when I put this inside, it's a 4 or 5 out of 10 now. Okay, so let's just hold it where it's comfortable. Is this okay? Yes, this is okay. But every time you go here, a little bit further inside, it bothers me. Sure, then we just move it back, okay? So there's nothing wrong with just holding it out a little bit just to get used to, again, from a nervous system standpoint. It's the same thing as if you're afraid of spiders. If you are deathly afraid of spiders and you hear that there's a spider on your foot, your whole nervous system is gonna go into a panic. But if I told you, if you're in Florida and I said there's someone in Kansas right now that has a spider on their foot, you're probably not gonna have the same exact nervous response. You might have like some sort of still sympathetic response, or oh man, that's kind of scary, but it wouldn't be the same response as if I said it's actually on your foot. So it's the same thing here, that just you don't want to have a threat to your nervous system. It has nothing to do with stretching out the vulva. It has nothing to do with stretching out the vaginal canal yet. We get to the point where that will be a factor as well. What we're looking for is, can something be there, and can you just let it be there so that it doesn't cause that response? And you'd be surprised that just by changing the words and the way you do this, people are like, oh man, I was able to move up in the dilators much easier by just listening to my body. Okay, and Jane's saying it's helpful to warm dilators. Sure. So so that's a good point. I don't often say that, but that makes a lot of sense. And some people actually, Jan, you may want to share too about some people like the cold too. So some people actually have them cold as well. But yeah, that's a good idea to have it under warm water. That may be helpful for some people as well. I love that. See, I just learned something tonight. I've known about it, but I haven't really done that in my practice. So that's a good point. Okay, so if we can see that so that's phase one, is going from one dilator to the next. Now, here's where it's tricky. I purposely try to trick the nervous system each time they work with me. I may use the dilators with them, or when they use them at home, okay? What I mean by that is the next time they use the dilators, I tell them just try to use the second one without the first. But then the next time, I want you to go back to just the first, but this time, instead of just putting it inside, I want you to try and move a little bit so you get some friction there. And they may say, you know, what's weird is I can't move it at all, but I can hold it in there. Okay, cool, then just hold it. But some of them will say, you know, for 5 minutes, as long as I hold it for 5 minutes, then the other 5 minutes I can move it and then take a break and then move it again. And the idea is, again, you're getting that nervous system to get used to different movements, pressures, that sort of thing, and then you can progress to the next size. The ultimate goal, and this is what I tell people, it's not just to kind of push the dilator in and wish and hope that everything goes well. We want to mimic the same kinds of things, like can they have movement in and out, right? Can they tolerate that? Can we have them on purpose stretch from side to side? Does that bother them? And then I even go one step further at some point and have them do more functional things. I want you to get into the position that really bothers you. So for example, if that position is kind of on all fours and then seeing if they can put that in that way, does that bother you still in that position? So you want to match where they're having their pain. Can they use these? Okay. There's another side note for dilators. You can see that they get much longer as they get bigger. So people think they have to stick the whole thing in. And just remember that the vaginal canal is only a certain length. So it's not as important to get the whole thing in as it is just to where your comfort level is with it. Okay. Obviously, if you're just getting a tip in, that may not be enough excursion there. But you definitely don't need to put the whole thing in when they get longer. Just keep that in mind too. We have Pocahontas here. So performing pelvic floor muscle eccentric contractions and diaphragmatic breathing helps to initiate dilator use and downtrain the nervous system. Right. So one of the things I didn't talk about, which is a really important point too, is that this is going to be different for each person, by the way. I want to explain something because this is also a really great point. So thank you. If I'm going to put this in, whether I'm helping someone or they're doing this on their own at home, okay, this really helps. Some people do really well by taking a nice inhalation, and then the pelvic floor will drop a little bit or lengthen, and they can go and put that inside. Other people do really well actually telling them to contract their pelvic floor, relax, and then they feel like it really relaxes for them. So there's not necessarily one way of downtraining the nervous system. It could be that a contract creates relaxation. In many of those patients, if they contract, it might take them 5 minutes to even reach baseline again to relax. So I check, this is part of my assessment that I'm doing ahead of time, is figuring out, are they someone who when they contract, they'll end up staying contracted, or does it work really beautifully for them to contract? One of my favorite cases I ever worked with, this is someone who had significant vaginismus, and she went on to, she's now happily married, and she's had intercourse, no problem for years. And one of the things, the sticking points for her is every time I told her to relax her pelvic floor, she went into what's called paradoxical contraction. So she went even tighter, okay? And then when you would say, I want you to contract as hard as you can, really contract, this thing happened where everything opened up. So what she started doing at home is actually saying, okay, I've got to contract hard. And every time she thought of contracting, it would open up to the point where she could finally use dilators for the first time, because her cue for her nervous system, for whatever reason, was contract. So when she started to have intercourse, that's what she did. Is she said she started thinking, she just thought of the word contract. Now, could we at some point change that and have her not have that association? Sure, we could have done that. But she was really happy with that. She had a tool that she could use to say, okay, contract in her head, and then everything just relaxed. So it's really important to figure out for each person what that is for them to lengthen a little bit so that they actually have more opening there, so you're not fighting it from the beginning. And this is vaginal and or rectal. It can be both. It's either or. That works really well for that too. Okay, and on this note, we'll just take a little break to say, regarding rectal, we'll take a break to say that when you, particularly for rectal, you want to make sure that it is something that is made to go in the rectum. It has to be something that has a stop to it. There's a lot of toys out there. There are anal toys that are made. They have like a stop to them to make sure that it's not just going to keep going in and slipping up. Because that's what'll happen is it's like a vacuum. So if you don't have something, like if you just put in, I don't want this visual, but if it was something that didn't have a stop to it, there's a chance that it can just get sucked up. And this is why you see these ER stories where someone went in with an impaled something in their GI area because it just got sucked up. So if you're going to train someone or they're going to use anal, anything to do with the anal rectal area, make sure it has some sort of stop to it and make sure it's made for that area. Okay, that's super important. There was a question earlier that I missed that I want to go back to about, I think it was to do with episiotomy scarring and what you can do for that. And that is a good question. It depends. I would look at the tissue and where it is. In some people that are in the first few years after delivery and they have an episiotomy pain and that's the problem they have, I would do a lot of touching desensitization that we would treat around scar tissue, have them even take a dilator and just do some gentle tissue work here. This may be a person that would benefit from a little bit of lidocaine there just to get that desensitization there with it. Like I said, I'm not going into that, but I do a lot of alternating lidocaine and not lidocaine with some patients as well. But if they have still this problem and a true sensitivity at the episiotomy area, what we also look at is, do they need a short-term amount of local topical estrogen there? Is there some sort of de-estrogenization at that area? And they would benefit from having a little bit of topical estrogen for 3 to 6 months just to help that tissue there. So maybe it just needs some help. We see this also with older women. I see this, actually, this is really an interesting thing where someone will say, I didn't have any pain with intercourse whatsoever or any pain around my vulvar area at all. And then suddenly I hit 60 years old or 65 and I have the worst pain right where my episiotomy scar was. I've never had a problem with it. And that is like a clear, like you just like the signals go off. That is definitely a change in estrogen in that area. And they probably need some local topical estrogen right in that area. And if they are past the age of 55 or so in that area, this is something they probably have to continue using a low dose type of estrogen there, because as soon as they get rid of it again, it might start coming back, that discomfort. So hopefully that's helpful as well. But there are ways definitely to deal with the actual episiotomy scarring specifically. Okay, so let's go back to dilator progression. So we talked about how there's, you keep progressing in size, right? But again, I tell patients, and this is super important too, I will guarantee them that there are going to be some days where they have to go down a size or 2 or 3, okay? It really may be that they have to go down in size. It's not always like up, 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 up. It really is, I say it is not, you are not doing anything wrong. It doesn't mean you've taken a step back. It's the nervous system. Think about it. Some days we're more hyped or our nervous system's constantly changing, right? So if that's the case, we just say just go with it that day. Just go with a lighter, like a smaller amount, smaller dilator, and then come back to the other dilators later. It is not a big deal. So just keep that in mind too. Okay, that's really important. So as they move forward, we're going to talk about the transition between, so now you've been using dilators relatively successfully, but now how do you jump to now being able to have finger touch there, a penis inside, like what do you do to get to that? Now there's this whole other leap you have to make, right? So we're going to talk about that. Someone is asking, high tech, and let's see here. Do I need to get prescriptions for any kind of estrogen cream or any topical stuff you're talking about? Good question. I'm always a believer of less is more. So if you can get away with just using lubricant, just use lubricant. There are other things on the market that are over the counter that can help vulvar tissue and or at that episiotomy area. And that could be as simple as a coconut oil that you put on that area. There's now been some reports through research that putting too much of it inside vaginally can lead in some cases to some people having slightly increased risk of UTIs or yeast infections. But again, and some people use it regularly every day and don't have that problem. So if you notice you suddenly got UTIs from it, then that may not be the best route. But definitely on that episiotomy area, so where that superficial transverse perineum is, you can absolutely try first with lubricants for any kind of inside penetration and potentially some coconut oil there. There are a variety of other things on the market. There's I was going to say Jolva, but I'll get there in a second. There's it's the other one I'm thinking. There's V Magic, is that it? V Magic. There are some aloe products that people use that they really like. I think Desert Harvest has one. So there's a lot of natural things, but again, less is more. Some people start putting too much on their vulva and they end up having all these other problems happen from it. So I'm more of a believer of don't just throw everything on there because you can. Okay, I'm back. Yeah, I don't know. It said it had a poor connection and then it said, you know, you were lost or something. So that was it. But we'll see if other people start coming back on. We'll see who the real Dilator wand fans are that come back on again. So sorry about that, but I have no control over that per se. So I will just wait for a second and we'll let everyone come back on. But I was talking about how there are different kinds of creams you can put at that episiotomy area or really anywhere in the vulva. If someone has vulvodynia. We didn't really get into vulvodynia this time, but basically that's another reason to potentially use. I really like dilators for vulvodynia cases as well. Okay, so let's talk about if you're not going to use estrogen, you decided for a variety of reasons that estrogen is not going to work for you, you can certainly use products like coconut oil. Some people use an emu oil. There's, you know, I've even seen people use vitamin E, or they'll use, and again, none of this is really studied very well in terms of what's the best one. There's varieties of all that stuff. Oh yes, I worked with vulvar specialists for many, many years. We had vulvodynia clinics and things, so I very, very well versed in treating vulvodynia. That's one of my favorite topics as well, and lots of controversies with that as well. But for this purpose, we're going to stick with the kinds of creams and things right now, and then finish off talking about dilators. So if they're not getting any success, they continue to have an issue either at, and this is important, where that episiotomy area is, at the vestibule, hymenal tissue, clitoral area, or urethral area. Those are all basically the same embryologic origin. So that, to me, when someone says they have that sensitivity in all of those areas, or at least one or two of them, I start to think that there could be some form of an estrogen deficiency there. It could just be short term, but it could be there. I'm just trying to catch the questions before I lose them. Yeah, I'll get to that again, Jane. Thank you for that question about do you use small dilators and then always progress the next time? And I'll talk more about the progression again. I'll make sure I get to that again. So all right, so you're going to go in the order again of least amount of stuff in it to more, and it would be basically like those oils I talked about. It would be something like I said, aloe. There's Desert Harvest has a really nice aloe cream that some people use. There's Replen's type of cream that is out there on the market, and then there was something else I said. I'm trying to think what it was. It was that V Magic one. Okay, so those are more of the basically over-the-counter types of things. Now there is something you can get over the counter too. That is called Julva, Julva, very clever name. And Julva is actually, it has all these more like natural types of ingredients. The one thing that's interesting is it has glycerin, which I was a little bit surprised, but that's an aside. But what it also has in it is DHEA. Finally, the FDA cleared DHEA. And it's what it does is it's not estrogen or testosterone itself, but it converts to some form of it to estrogen and testosterone. So for some people, they actually find it's even more helpful than just those creams or moisturizers. They actually get a little bit of a DHEA effect at that area. So that could be something you can get over the counter, Julva, that sort of thing. Now, in some cases though, we find that really they'll benefit from some form of estrogen cream. Local, topical, it is not the same as rubbing it in your arm or taking it orally. It needs to really be at that tissue. And that's something where you would talk to your physician about that. We don't prescribe that in pelvic physical therapy, but I certainly, in doing this so many years, know a lot about that. And it's usually estradiol, which is not the same as estriol. So it's estradiol. And there's people that just can't use any kind of estrogen for a variety of reasons, GYN, cancers, and breast cancers. But even then, sometimes they're okay using a small dose of it. So that's why we always say talk to your physician about that rather than us making that recommendation. So hopefully that helps. I think Synergy, Celia said thank you for sharing that. So hopefully that is helpful to all of you. All right, so to get back to the progression, Jane had said a comment. I want to go back there before we jump again, which is when you go up, I was talking about I think I skipped around a little bit, but it's kind of the way that I do treatment, so I want to make sure I go back to this. If you have a small dilator, the next time that person uses a dilator, I want you to know I purposely have them do different things every day. If it's too confusing, I don't, but I want to trick their nervous system a little bit. So sometimes I'll have them use the smaller one again for a few minutes and then go to the larger one. Sometimes on purpose, I have them just try the next time with just using the larger one and see what happens. But only if they were successful with this one in the whole way there. Sometimes people say, but I'll never be able to go the next size up. They start to get frustrated. So I don't necessarily even wait sometimes for them to be able to do this one. I'll say, start doing some of this one too the next time. So yes, most people, I would say, Jane, I have them put in the smaller one for a few minutes and then go to the next one if they were successful with this one and felt they could hold it in and it wasn't higher than a 3 or 4 out of 10. But a lot of times I have them do just a few days of just one size. And then we have a transition point where they do the smaller size, the larger one, halfway through. And then when they get to the point where they can just use the larger one, then we have them just start using the larger one for a little bit until they can again do that transition. So it becomes like a stepping stone like that. But on purpose, sometimes I have them mix it up because I want them to get used to other sizes. And sometimes I'll have them take a big one and put it out on the outside of the vulva for that day. Because again, I want them to get used to other sizes being there. So there's a critical point that happens. Let's use the example, and this is not, I try to make sure that I'm being very clear that we're not just talking about cisgender, heterosexual sex. There's all sorts of things. Like I said, there's finger penetration, there's anal sex, there's all things we can talk about that can be in the realm of talking about dilators. But for purposes of this, I'm going to explain this in terms of someone with vaginal anatomy that wants to have intercourse, with penile intercourse, okay? There's a transition point, okay, where you can go from having, doing really well. So you went to, where's my big blue here? Okay. All right, Jane, we got big blue here. All right. So we've got big blue, and you don't have to use this, but they've decided they want to go up to big blue. And they can do this no problem. They can put this inside, they can move it in and out a little bit. They can push it around in different ways, and they don't have a problem. They have very minimal discomfort. Again, it's okay if they have a 2 out of 10 discomfort. That is still okay. But they'll have minimal discomfort, okay? But this is where it gets tricky. They say, well, what's the best way now? I want to start having intercourse. I'm ready, but what do I do? And I have to tell you, this really depends on the couple and what's going on. So it could be that they try as a couple, sorry, let me back up. The person tries first to put this in. They move it in and out on their own and they get used to it being there, and then the door opens and their partner comes in and they've already they call it like a warm up. They're gonna warm up with the dilator and then they start to have intercourse, and they try that after. And this goes to the side. There are some that we recommend, they like to have it as part of partner play, where the partner will actually play a role in actually trying to push it in. And then when they feel comfortable with that, they can then slide in with a penis instead and not have this there, okay? So that is one way to do it. Now, I can tell you this, that if you think about it from a nervous system standpoint, you can see how some people would prefer to do it on their own and then have their partner come in after and not be a part of the dilator. That just makes them freaked out. They don't like it. And you can see how other people will feel much more comfortable if their partner is using this as part of like a foreplay and part of something they're doing with it first, and then they can easily transition. We have some that don't even want to use it at all during that session. They feel comfortable that they've already been using the dilators for a while, so they're like, now I'm going to try having intercourse without anything. I just want to see if I can do it without it. So those are the 3 primary things, but then there's a variety of other things we try and test with them. Like it could be all sorts of things, like they use smaller dilators and have them do a progression first. There's so many different variations, but I think the key, if you can get what I'm saying for this, is it depends on the person's individual needs and their fears, their nervous system, and where you are. And I guarantee you, this is what I was saying, when someone asked the question, well, what if they've gone through the dilators but they still have pain? Well, then I want to troubleshoot that. Is it something in the way they're doing that transition? Or is there still a small area that just needs a little bit of lidocaine and that's it? Like they're so much better, but there's just this one sensitive area, and as long as they put like a dab of lidocaine, they have 0 problems. Or is it something else? So we're still kind of troubleshooting the whole way. But like I said, there's a very high success rate if you're using these the correct way that I'm talking about, and think of it from a nervous system standpoint. versus thinking of it from just pushing it in and stretching. Now, on that note, I'm actually glad I remembered to talk about this. There is a form of stretch. Some patients will say, oh my gosh, I feel so much pressure, I feel it stretching. Oh my gosh, that feels terrible. I mean, just the fact that the vaginal canal does stretch and it does need to have, in order to get comfortable having something there will be some pressure and there will be some stretch. And that is part of what you do for dilators. So that is a component of it. So I'm not taking away from that component. But the people that have struggled with the programs they've seen online that aren't doing that is that they focus too much on the stretch. So one of the things that I hope to do is to take these kinds of videos and turn them into some things that are more online for people to access, because they really need to know that you're not just pushing it into stretch. I had a patient come in and she said, you won't believe this. I got through all 8 of my dilators in 1 week. I can't believe it. And I said, okay, so your dilator 8, how much of discomfort was it? And she said, it was an 8 out of 10, but I did it. And I was like, no, that's not going to get you anywhere. The 8 out of 10 is not what we want. So it's not just pushing it in and getting it to go there. It's what the nervous system is allowing. How do you feel? People will get frustrated, but like I tell you, there's always a way. We just keep figuring out what that is. Does that mean there needs to be more pharmacology involved? Does that mean, and just short term, it doesn't have to be very long at all. Does that mean they need more meditation or guided things before? Does it mean sex therapy as well? Does it mean they need some sort of different intervention or way of working with the pelvic floor as well? So there's lots of creative ways to do this, but I think that there really is a place for these dilators, and it's just a matter of figuring out for each person what that is. So are there any other questions? I know this is part 2. This is round 2 of what we started, but I really do appreciate those of you who have been on. Like I said, I actually, believe it or not, I've battled being in front of the camera. I don't like being on video typically, and it's been an evolution over the past year to just say, you know what, I'm just gonna do it. And so this is the first IG Live I've ever done. And like I said, I love teaching, but I just seems strange when you can't have that interaction. I'm very much about like having people in front of me and chatting. So without that, it seems a little strange to me still to talk into a phone, but yeah. So thank you all for joining here. And I hope this was helpful, and I'd love to, if you have any more questions, just let me know. I think we're saving this. It should be saved so that it will actually be able to play if you did miss any of it. And I hope you all have a good night or a morning wherever you are in the world. Thanks.